Hi, everybody. I'm excited about this talk by Dr. Caroline Apovian, who is a longtime colleague of mine, past president of the Obesity Society. She's also professor of medicine and pediatrics at Boston University School of Medicine and the director of the Nutrition and Weight Management section of the Division of Endocrinology. I'm endocrinology, diabetes, and nutrition at BMC. Caroline has a wonderful, positive approach to helping our patients manage their weight, and I know you guys will enjoy this talk.
Thank you, Dr. Tischler. It's a pleasure to be here today to talk about obesity. These are my disclosures. And the first thing I want to say about obesity is that it was recognized as a disease by many associations, starting with the American Medical Association in 2013. And this was a seminal event because the designation of obesity as a disease mandates that primary care providers and other specialists treat this disease with the tools that we have available, which I will talk about. But this was a seminal event. Prior to that, many people thought that obesity was simply a matter of willpower. We now know, based on decades of research, starting with the discovery of leptin in 1994, that is secreted by adipose tissue and travels to the brain in an area of the hypothalamus called the arcuate nucleus and indicates satiety. It activates the neurons that lead to satiety. When there is resistance to leptin, which I'll talk about, the neurons don't get this signal and the body defends a higher body weight. And that's what we think has been happening over the past 100 years. Somehow in our probably toxic food environment, maybe an endocrine disruptor in the food supply, most of us are defending a higher body weight than we normally would be genetically programmed to defend without that endocrine disruptor in the environment or in the food supply. Since the discovery of leptin, we have also discovered many other hormones that come from the gut primarily. So, for example, in the stomach, we have ghrelin, which is in green. Why is it in green? Because it's one of the only hunger hormones that we have discovered so far. There are probably more, but ghrelin, when it's secreted from the stomach, is a short-term hunger hormone, goes to the brain and makes you feel hungry. It is secreted right before you eat a meal. When you see the food, you suddenly become hungry for it. Insulin is also a very potent, not only does it maintain glucose homeostasis, but it also indicates satiety in the brain. In the POMC neuron, ghrelin works on the agouti-related protein neuron. There are two sets of neurons in the hypothalamus. The main thing that you need to know is that all of these hormones regulate satiety and hunger in the brain. CCK is another one, satiety hormone. GLP-1 is a satiety hormone. Not only does it help insulin secretion, but it also produces satiety. Oxantimodulin and PYY are others that come from lower down in the intestine. All right, so these peripheral signals are released from all over the gut, the pancreas, and adipose tissue that are integrated into the hypothalamus to regulate our body weight and energy expenditure. And they are also sometimes relayed right to the brain via the vagus nerve. So what you notice about this is that there are many hormones secreted and that some of these are redundant. And the redundancy means that you are ensured that no matter what the human body will get, no matter if it's available, it will get the energy it needs to survive. And that is relayed by body fat. So you need body fat to survive, to have the energy that you need for cellular processes. There are two centers in the brain. So the homeostatic center is the one that I just talked about in the arcuate nucleus. But there's also a reward center that I see as working above the homeostatic center. And that also receives signals. And that is the center that, for example, makes you want to eat that piece of chocolate cake, even though your homeostatic center says that you're full. The reward center is the center that allows you to enjoy a piece of chocolate cake or ice cream after your meal. And those get signals from dopamine and serotonin. And it's also the same center where our sexual inputs come in, and also the opiates, so drug addiction, alcohol, and the reward system for food. All right, so this beautiful system of body weight regulation was really essentially discovered starting in 1994 with the discovery of leptin. However, we didn't really translate this until much later on. This very elegant study was done by Sumitran and colleagues and published in the New England Journal in 2011. So a long while after this system was discovered, to help translate what it means for humans to defend a certain body weight set point. So this set of researchers took 50 men and women with obesity. Average male weight was 233, average female weight 200, and put them on a very extreme low-calorie diet for 8 weeks. They only took in 500 to 550 calories a day for 8 weeks with OptiFast shakes, protein shakes, and some vegetables. Very, very tough diet to stay on, but they did. At 10 weeks, there was a 30-pound average weight loss, which is a very significant 14% weight loss. At year 1, after the study was over, they followed patients up to 1 year. And as you might expect, patients regained some weight. It's amazing they didn't gain all of it back because of the system that I just told you about. They gained 11 pounds average back. And these researchers also did hunger questionnaires, and the patients reported feeling more hungry and preoccupied with food than before the weight loss, gearing you to regain weight. So the body continues to fight against the weight loss long after the dieting is stopped. They went one step further and measured the hormones that I was just talking about. So here is a graph looking at the time and the weight loss. So 8 to 10 weeks, they lost an average of 30 pounds. And then this is the ITT analysis, and here are the patients who actually completed the study. But in essence, most patients regained weight out to a year. And what happened was when they measured all the hormones that I was telling you about, they noticed a reduction in the satiety hormones. Leptin levels were reduced by 65% as compared to baseline before they lost the weight. PYY, CCK, insulin, and amylin levels were reduced. What does that mean? These satiety levels went down, and so patients were much hungrier than before. And the hormones that they found were increased were some of the hormones that we think regulate hunger. So ghrelin levels increased. Ghrelin is one of the only hunger hormones that we know. And so we see that this 10-week lifestyle-based weight loss intervention in patients with obesity that produced a 14% weight loss produce changes in 8 hormones that encourage weight regain. This is why obesity is a disease. It cannot be managed successfully for most people with lifestyle alone. So there was a sustained elevation in the appetite stimulating hormones and decreases in the appetite suppressing hormones. All right, so the net result of these changes is for the body to regain the weight because it's defending a higher body weight set point. And again, we think the reason why is because there is some kind of dysfunction, maybe from an endocrine disruptor in the environment, maybe simply because of an excess of calories. The body, the brain realizes that we have a lot of food available and it stores as much fat as possible because we have genes that regulated our hunger and appetite from eons ago where we had to forage for food. We still don't know the reason why, but we feel, and this was corroborated with animal studies, that when you make animals overeat and develop obesity, it has been found that there is hypothalamic injury around this area, inflammation that doesn't let the signals get in. So when the brain is damaged around this area, the brain can't tell how much fat is stored and becomes resistant to the key hormone leptin, and you defend a higher body weight set point. And that's what we think is happening. Are there other factors that are involved here? Yes, we think that some medications can exacerbate weight gain and cause people to maintain a higher body weight set point. Medications such as insulin, steroids, beta blockers, antihistamines, and some of the antidepressants and antipsychotic agents. But the main problem is a defense of a higher body weight set point because of some kind of perturbation in this very elegant, redundant system in the arcuate nucleus. And we think that there is hypothalamic injury. All right. Even though this seems very dismal, there is a lot we can do to help patients lose weight and keep it off. The guidelines that were published in 2000 and updated in 2013 talk about setting realistic goals with your patients. So the goal would be, with lifestyle changes, to decrease the body weight by 5 to 10%, because a 5 to 10% weight loss has been shown to lead to reductions in the risk of developing diabetes, hypertension, stroke, and heart disease. Focusing on behaviors that can be done to elicit this 5 to 10% weight loss, and in the interim, maintaining that weight loss with frequent follow-up. So let's go to question 1. According to the 2013 obesity guidelines, what is the best diet for weight management? Is it A, a Mediterranean diet, B, the DASH diet, C, no diet is the best, or D, Weight Watchers? All right, let's get voting here. You know the answer. Best diet for weight loss. Weight loss, remember. All right, I want to get 200 people voting. All right, okay. All right, so this was kind of a trick question, but I didn't say what's the best diet for health. I said for your weight. So the answer is All right, so we're getting there. All right, so the answer is click. Okay, thank you. All right, so you were right if you said none. There is no ideal diet for weight loss or weight management because the diet that a person will adhere to is the best diet for them. You are right if you said Mediterranean diet, DASH diet for health. And that's still a debate out there. But for weight loss, you can go on any diet that you want as long as you're able to adhere to that diet and get the weight loss. And you can read about it in the 2013 obesity guidelines. Okay. So here are the 2013 obesity guidelines. This is a very important document recommending that you use the BMI to identify risk of overweight and obesity, that you also use the waist circumference. What are the BMIs? BMI over 25 is overweight, over 30, obesity. The waist circumference over 40 inches if you're a man, 35 inches if you're a woman, gives you a higher risk of developing diabetes, heart disease, hypertension, and the metabolic sequelae of a high BMI. 3 to 5% sustained weight loss reduces risk factors and the risk of type 2 diabetes. Prescribe a set number of calories per day. There's no ideal diet. And this is the strongest recommendation that came out of these guidelines. You must advise people with obesity who meet the criteria that surgery is an option. Very important. We don't use enough surgery. So question 2, what is the BMI criteria for the anti-obesity medications? A, BMI over 27 with one or more comorbidities, or 30 with none. BMI over 30, 2. C, BMI over 25 with a comorbidity, or over 30 with no comorbidities. D, BMI over 30 with one comorbidity, or greater than 35 with no comorbidities. Let's vote. I know you know this. Anti-obesity medications. All right, I think I gave you enough time to get the wrong answer. The answer is A, BMI greater than 27 with one or more comorbidities, or over 30 with none. This is very important. Read the guidelines. The 2013 guidelines stated explicitly, because of some of the risk of the anti-obesity medications, BMI over 30, which is class 1 obesity, but over 27 with a comorbidity or two, we know those people will end up with diabetes, metabolic syndrome if we don't do something. So that's very important to know. And that number came from the added risk of these people are still overweight, right? But they already have a comorbidity. So we know that they're at higher risk. They have a high waist circumference. So remember those numbers. Now, the pharmacological management of obesity, the Endocrine Society guidelines came out in 2015 because the 2013 guidelines said nothing about medications. It only talked about diet and surgery. So we felt that we should put out a guideline for medications. Why didn't the 2013 guidelines state anything about medications? Because at the time, we didn't have many medications approved by the FDA. So remember, they came out in 2013, but we reviewed 5 years of literature. And in 2013, it just so happened that the FDA approved 5 medications for obesity management, which we talk about in these guidelines that were published in 2015. And in these guidelines, again, we say again, drugs for BMIs over 27 with a comorbidity or BMI over 30, and bariatric surgery, different criteria now, BMI over 35 with a comorbidity, and usually it's got to be diabetes, heart disease, or sleep apnea, or BMI over 40, criteria for bariatric surgery. And you should apprise your patients who cannot lose weight with diet, exercise, and drugs, and they have these kinds of BMIs, to go for bariatric surgery. Very important. All right. In the United States, there are 116 million adults who fit the criteria for drugs for obesity, and very, very few get these medications. Only 2% receive these drugs. We need to do better than this. Look at how many people with diabetes are treated with drugs, almost all of them, drugs for diabetes, and we're not doing a good job with obesity management in terms of drugs. We need to do better. We need obesity medicine to be recognized by the American Board of Medical Specialties as an official subspecialty. Here are the drugs that we use. Notice lorcaserin was taken off the market last February because of concerns of cancer. So we don't have that anymore, but we do have 5. Phentermine combined with topiramate, and here's the weight loss, about 7%, placebo subtracted. It means that the placebo on diet and exercise get 2 to 3% weight loss. So in reality, your patients are going to get more like a 9 to 10% weight loss with this medication combo. The combination of naltrexone and bupropion, about 5 to 6% weight loss. Again, add the placebo back in and you get about 8% weight loss. Liraglutide, the first injectable for obesity, gives you again about a 5% weight loss. You have to add back in the placebo subtracted weight loss. You get about 7 to 8% here. And orlistat is the only one of these 5 that works in the gut. The others work in the brain to induce satiety. And orlistat works in the gut to malabsorb 25 to 30% of fat calories. You can combine these and they work very well to help your patient lose an extra 6 to 7%, which ends up being about a 10% weight loss when you add in the lifestyle change. Okay, how do you assess efficacy and safety? If your patient loses greater than 5% at 3 months and the medication is safe, great. If they don't, stop the drug and use another medication. You have 5. Bariatric surgery criteria, as I said, BMI over 40 or over 35 with a serious comorbidity. And the ASMBS, our surgical society, indicated in June that bariatric surgery is not elective during the COVID pandemic. We need to help patients lose weight, especially during this pandemic, and bariatric surgery is not considered elective. Bariatric surgery, why isn't it elective? It gives you the best long-term weight loss result. You get 33% weight loss. Remember I told you with drugs, 5 to 10%? Well, look, 33% weight loss with surgery, with the bypass. With the gastric sleeve, it's more like 25%. The band is about 25%. But this study gives you 20 years of results. And even at the end of 20 years, patients with the gastric bypass have kept off about 25% of the original, 25% weight loss compared to the original 33%. And surgery has been shown to reduce mortality, and specifically diabetes mortality by 88%. Diets, exercise, and drugs cannot do this. We only do about 2% of the eligible population in the United States actually gets surgery every year. And again, we have to do better than this. Many studies have shown that gastric bypass surgery and the sleeve gastrectomy does a lot better than lifestyle and medical management. 23.8% weight loss here compared to 7.3% weight loss with lifestyle and medical management. The difference is a whopping 17% weight loss. So in the last few minutes, I'm just going to talk about obesity and its connection with the COVID-19 pandemic. Many studies have now shown that those who are at high risk for illness, severe illness from COVID-19, are older and who live in a nursing home, and of certainly chronic lung disease patients and serious heart conditions, but severe obesity with a BMI over 40 is a significant factor, especially in younger patients. Why? We think it has to do with the immune system, but we're not sure yet if it's excessive inflammation or not enough immunity in obesity. We have to figure this out, but the New York City data shows that this data from Cornell, obesity is a risk factor for admission in younger patients. Early data from China and France also corroborate that those with high BMI were had more than twice the risk of severe pneumonia than lower BMI with COVID. And this is another study from NYU showing the same thing. The most important features for admission for COVID-19, older age and obesity. There are challenges in the management of patients with obesity who become ill and go to the ICU. It's hard to intubate patients. It's challenging to do diagnostic imaging and to move those patients. So be careful. So here are some references, and to summarize, read the 2013 guidelines, aim for 5 to 10% weight loss with diet, exercise, and drugs, and bariatric surgery is the best option for patients with severe obesity. Thank you so much.
Thank you, Caroline, and thank you for sharing the new insights that we have about obesity and COVID-19. And I think just for our audience, really two of our talks today, one on addiction and Caroline's talk on obesity, have really encouraged us to think about these conditions that we might have formerly thought of in a much more judgmental way, or not necessarily as a disease, really in much the same model as we think about all of the other chronic diseases that we take care of in internal medicine. And I think it's incredibly enlightening and will help us all be better doctors to think about it this way. So thank you so much for being here this morning.
Oh, thank you, Dr. Tischler, for having me.